So we'll be talking about beta blockers, calcium channel blockers, and cholesterol lowering agents briefly. So when we're talking about beta blocker, they are the same thing as beta adrenergic blockers. So you'll be hearing beta blockers, beta blockers, beta blockers, beta blockers. So what do you understand by beta blockers? I want to see your response, Moses. You have been using it. Please let's respond. Beta blockers, beta blockers. They reduce blood pressure. I'm not asking for the mode of action. Okay, what are the examples of beta blockers? Okay. Propanolol. Okay. Indolol, atenolol. Okay, so obviously most of these drugs ending in lol. Lol. Yeah. So most beta blockers ends in lol. So that makes it easier for you to remember. All the laws. Yes. All the laws. Okay. All the laws. So do you know that we have so these beta blockers now, that means they are blocking something. Beta blockers are blocking something. What are they blocking? I want you to understand the mode of action. That's why I'm asking you this question. So that you just cram it. And all you know is okay, atenolol is beta blocker. And why is it a beta blocker? What is it blocking? Epinephrine. Okay. What is beta blocker? What are they blocking? Thank you. They block beta receptors. Thank you. Thank you very much. They are blocking the beta receptors. That's why we call them beta blockers. You have to get used to, you have to be vast in pharmacology. Just cram pharmacology and for cramming sake. You have to know it. So they block the beta receptors. And we have beta 1, beta 2. We have beta 1, beta 2. Where is beta 1 located? Beta 1 is located where? Beta 1 receptors is located where? Sorry, I mean beta 1 receptors. Where is it located? Beta 1. Where is it located? Because of our time in the heart muscles. Thank you. Okay, someone has responded. Beta. What about beta 2? Well, just know that beta lungs. Thank you. God bless you. Lungs. You can see them in the lungs. Be in the okay. Lungs. Thank you. Okay. So you know what? When you have the understanding of this thing, pharmacology will not be anything to you. It will not be anything to you. So this beta 1, it's fires up the sinoatrial node, atrioventricular node, it fires it up so that the cardiac, the rate at which the heart is contracting can increase. That's what beta 1, that's what it does. It fires up the heart muscles, the SA node, the atrioventricular node, these are the conductive system of the heart. So this beta 1, they speed up the rate of the cardiac contraction. So that the stroke volume and the cardiac output can increase. So that is their work. So now when we are talking about beta blockers, we have different types. We have the selective and the non-selective. Let me go back to my slide and read. So beta blockers block the beta receptors in the heart. which result in decreased heart rate and decreased force of contraction. So you can see that when I was telling you that beta receptors are located in the heart, and I've told you what beta 1 does. Speed up cardiac contraction. It's increased speed of the SA node, the anteroventricular node, all those stuff. It speed them up so that what? The cardiac, the rate at which the heart is contracting, it increases cardiac contractility. Now, when you now give a patient beta adrenergic blockers, it will now go and block that beta 1. And immediately it blocks the beta 1, what will happen? Will there be increased cardiac output again? Immediately the beta 1 is blocked. You not know the function of beta 1. So, so there will be decreased cardiac output automatically. There will be decreased cardiac output. So that's just the way it works. And immediately there is decreased cardiac output. Do you expect the blood pressure to be high? Will the BP be high? It will be low, thank you. That's just the simple rationale. That is just the simple rationale. You can see that it's straightforward. So they result in decreased heart rate and decreased force of what? Contraction. There's something we call negative inotropic, chronotropic, and dromotropic. So beta adrenergic blockers are negative inotropic, chronotropic, and dromotropic. I hope we all know the meaning of what I'm saying. Nurses, do we know? So when you hear negative inotropic, chronotropic, and dromotropic, that is the work of beta blockers. Please let's respond. I hope we know the meaning of what I'm saying. We know the meaning of negative dromotropic. Okay, so from inotropic means the force. It means force. When you hear inotropic, that means force. Decreases the force of contraction. The force at which the heart is contracting. Beta blocker will decrease it. When you hear chronotropic, chrono in English means what? It means time. So negative chronotropic means it will reduce the rate. It will reduce the rate. And dromotropic means reading. It will reduce the reading. I hope it makes sense now. So that is how beta blockers work. I hope it makes sense now. Inotropic means force. Chronotropic means time. And dromo means reading. So that is how beta blockers work. They are negative inotropic, negative chronotropic, and negative dronotropic drugs. So that is what they are. Okay, so it makes sense now. So they block the release of catecholamines, epinephrine, and norepinephrine. That's another thing they do. They block the release of catecholamines. Sorry, I said they block the release of epinephrine, norepinephrine, and catecholamine. So what are these particular things I'm mentioning? These epinephrine, norepinephrine, catecholamines, what are they? What do they do in the body? Let's respond, please. What does epinephrine, catecholamines, what do they do in the body? They cause vasoconstriction, they stimulate cardiac activity. Okay. All right, so thank you. They play a role in the fight and flight response. So they cause vasoconstriction, and immediately there's vasoconstriction, what will happen? The blood pressure will go up. Immediately the blood vessels are constricted. The blood pressure will definitely what? They will go up. So they now block the release of all these what? All these catecholamines, epinephrine, or norepinephrine, thereby decreasing the heart rate and BP. And they decrease the workload of the heart. And immediately the workload of the heart is decreased, definitely there will be decreased oxygen demand. So the chest, the heart muscles will rest. So this beta adrenergic blockers, it affects both the BP and the heart rate. It affects both the BP. It has effect on the blood pressure and the heart rate. You know, I told you earlier on that they are negative, inotropic, chronotropic, and dromotropic. Now, we have different types. We have the cardioselective beta blockers, and we have the selective beta blockers. If you don't know it before, please know it again today. And you have to know the difference between the two. You have to know. So that is why I've listed them out in this table. You can see the cardioselective beta blockers. So what cardioselective beta blockers does is that they block what? They block only beta 1. Take note. Cardioselective beta blockers blocks only beta 1. They don't block beta 2. They do not. But when you give non-selective beta blockers, they block any beta they see, they will just continue to block it, irregardless of where those beta receptors are located. They don't care. But when you give someone selective beta blockers, it will only work on beta 1 receptors. It will not work on the beta 2. So that is the difference. So under cardioselective beta, we have the carvedilol, labetalol, nadolol, pindolol, propanolol, and sotalol. I think there's an acronym that I use, but I've forgotten this particular time. So you can look for your own acronym so that you can remember. So you're not going to mix them up. So they are two different things. Even though all of them are ending in lol, they have their different mode of action. Cardioselective beta blockers work only on beta 1 receptors, while non-cardioselective work on both. So there is something I'm trying to arrive at, and we'll still get there. Now, indications you can use for angina, dysrhythmia, hypertension, migraine headache. You can use it to prevent myocardial infarction, then glaucoma. Glaucoma. And I know I think you know the reason why. So for contraindications, beta-adrenergic blockers are contraindicated in clients with asthma. Yes, so this is where I'm going. It is contraindicated in a patient with asthma, in a patient with bradycardia, severe renal hepatic disease, hyperthyroidism, stroke, or stroke. So now, why do you think it is contraindicated? Who can tell me why is it contraindicated in a patient with asthma? There is something I'm driving at when I told you that we have cardioselective and non-cardioselective. Why do you think it is contraindicated in a patient with asthma? Why can't you give it to a patient with asthma? Actually, you can give. Because of beta receptors in the lung. I need a better explanation. Or let me ask, what type? I just told you we have cardioselective and non-cardioselective. You can actually give an asthmatic patient beta blockers, but what type can you give? What type of beta blockers can you give? God bless you. You can only give beta 1. Thank you. You can only give the cardioselective. When you give them the non-cardioselective, what will happen? When you give them the non-cardioselective beta blockers, what will happen to an asthmatic patient? What will happen? There will be bronchospasm. Thank you. There will be bronchospasm. Thank you. It will just go and block the beta 2, and the bronchioles will constrict. So that is why you have to know the difference between cardioselective. So you don't give it to a patient, you don't give non-cardioselective. You don't give it to a patient with what? With asthma. You give them cardioselective. Yeah, I'll give it. So I hope my explanation makes sense now. Please, who is confused here? We are all clear. Thank you. Okay. So carvedilol, metoprolol, bisoprolol have been approved for use in heart failure once the client has been stabilized by ACE inhibitors and diuretic therapy. So you can use it, although we say, okay, sometimes they will tell you not to use these beta blockers for a patient with heart failure, but you can use carvedilol, metoprolol, and bisoprolol because that has been approved once the client has been stabilized by ACE inhibitors and diuretic therapy. Beta-adrenergic blockers should be used with caution in clients with diabetes mellitus because this medication masks the symptoms of hypoglycemia. When you give patients with diabetes mellitus, when you give them what? beta blockers. Until your patient will die, you will not know. Especially patient with diabetes mellitus, because it will mask the symptoms of what? Hypoglycemia. And we all know the symptoms a patient with hypoglycemia, we all know the symptoms they present with. So beta blockers will go and mask it for you. So you will not know, the patient will not know. To your patient to what? To your patient, to you lose your patient. So you have to be careful when you're administering these patients. When you're administering a patient with diabetes mellitus, when you're administering, giving them beta blockers. So side and adverse effects can cause bradycardia. We all know that. Can cause bradycardia because it lowers the heart rate. It can cause bronchospasm in patients with asthma. It causes hypotension. So you have to keep on monitoring the BP. You want to check the pulse rate of the patients. It can cause weakness, fatigue, nausea, vomiting, dizziness. Then agranulocytosis, behavioral psychotic response, depression, the nightmares. Caution, hold. If there is bradycardia, you want to hold if there is bradycardia. If the BP is less than, and if the BP is, the pulse rate is less than 60. You don't want to give it to a patient if you check the pulse rate and it is less than 60. If the BP is low, obviously you cannot give 90, 60, and only hold if the patient is in acute exacerbation of CHF. Then another thing is breathing problem, wheezing. In a patient with asthma, in a patient with chronic COPD. It is bad for heart failure patients, but I've told you that there are exemptions. I think I just explained that now. So don't get confused. Then blood sugar masking. That is another thing. So you have to hold. You have to hold the patient is diabetic because it can mask the what? It can mask the signs and symptoms of what? Of hypoglycemia. What are your nursing managements? Monitor the vital signs. We told medication if the pulse or BP is not within the prescribed parameters. You have to monitor for signs of heart failure or worsening heart failure. Assess for respiratory distress, signs of wheezing and dyspnea. Instruct the client to report any form of dizziness, lightheadedness, nasal congestion. Then you instruct the client not to stop the medication. You don't want to stop this medication abruptly because it can cause what? Rebound hypertension, can cause rebound tachycardia, and an angina attack can also what? It can occur. Then advise the client taking insulin that the beta adrenergic blockers can mask early symptoms of hypoglycemia. We have explained that. So the clients taking insulin to monitor their blood glucose level. So because it can mask the signs and symptoms of hypoglycemia. So what it means is that when your patient is on beta blocker, you have to keep on monitoring their what? The blood glucose level. You don't joke with it. Because this patient will not know. There will not be signs and symptoms. And this patient can go into hypoglycemia. So you will know through what? Through the monitoring of the what? Of the blood glucose level. Instruct the clients in how to take their pulse, their BP. Instruct the client to change position slowly to prevent what? Orthostatic hypotension. They should change their position slowly when they are lying down. They should slowly move from lying position to a sitting position before they stand up. They don't just want to do it suddenly to prevent orthostatic hypotension. Instruct them to avoid over-the-counter medications. Cold medications, they should avoid it, and nasal decongestants. They should avoid all these medications because they can make the BP what? Can make it go up. Now let's go to calcium channel blockers. Calcium channel blockers. So what are the examples of calcium channel blockers? What are the examples of calcium channel blockers? Can you display the slide? You will see it. Go to your LMS, please, and download the slides. They are there. Because of our time, I don't want to. We have spent almost 1.5 hours, and I want to round off soon. Thank you. Nifedipine, amlodipine, the pain. Okay. Thank you. I wanted to ask you that there are 2 medications that are not ending with pain. And it's a calcium channel blocker. Thank you. Diaziazine and verapamil. Thank you. Okay, so let's continue. So calcium channel blockers, they block access to cells. They block calcium access to cells, causing decreased contractility. You know that calcium, we have all these various ion channels. We have these various ion channels, they have their role that they play. The calcium, the potassium, the sodium, and they have various roles. that they play. But what calcium channel blockers does is that it blocks the calcium access to the cells, thereby decreasing contractility. You know that calcium helps in what? In muscle contraction, be it muscles of the heart. So this calcium channel blocker will now block the access of calcium to the cells, thereby causing decreased contractility, conductivity of the heart, and decreased demand for oxygen. That is the mode of action of what? Calcium channel blocker. Calcium channel blockers promote vasodilation of the coronary and peripheral vessels. And it also has effect on the what? On the BP and heart rate. So you have to use it with caution in a client with heart failure, a patient with bradycardia, or patient with atrioventricular block. So examples, we have mentioned the examples. So let's keep this particular slide. Indication you can use for a patient with angina, hypertension, dysrhythmia, especially verapamil and diaziazine. Very, very important. You can use, I think we discussed this particular medication when we're talking about antiarrhythmic drugs. So you can use, they fell under the what? Under the calcium channel blocker. So side and adverse effects can cause bradycardia, hypotension, reflex tachycardia as a result of hypotension, headache, dizziness, and so on. No, let's move on. Nursing management, monitor the vital signs, monitor for signs of heart failure, monitor liver enzymes level. We have to monitor the liver enzyme level because they can also what? They can affect the liver. So when you are monitoring the liver enzymes, which enzymes are we talking about here? ASC. What's ASC? Please let's respond. Liver enzyme. Rennie, wow. Liver enzymes. Please let's respond. Thank you. Especially that alanine, okay, and aspartate transaminase. Thank you. Thank you. So you monitor the liver enzymes. And you have to know their normal range. Don't just monitor for fun. Monitor kidney function. So for your kidney function, that means you monitor the what? The creatinine and the blood urea nitrogen. These are the two majors, especially creatinine. It's a good indicator for kidney failure. Instruct the client not to discontinue the medication. Instruct the client on how to take pulse. Instruct the client to notify the primary care provider if dizziness or fainting occurs. Instruct the client not to crush or chew sustained release tablets. Yes. The one that is what? That is sustained release. They should not what? Chew it or crush it. Most of these medications, they are sustained released. Teach them about postural hypotension and to notify healthcare provider of signs of edema. Weigh patients. Report any peripheral edema or weight gain. Teach patients to avoid grapefruit juice because it can what? It can affect their absorption. Teach patients that constipation can be minimized by increasing dietary fiber and fluid. These are the side effects of the medication. So let's go to antilipidemic drugs. I hope I'm not rushing because I'm trying to consider you people so that I can release you. So let's go to the last topic for the day, which is antilipidemics. I want to round up today. So antilipidemic drugs, they are also known as cholesterol lowering agents. So antilipidemic medication reduce serum level of cholesterol, triglycerides, or low density lipoprotein. Now, you see this medication, you have to understand the lipid profile very well. You have to know the level. When you ask your patient, go and do lipid profile, go and do lipid profile. What are the things they are checking? When they ask your patient, when you fill form for them to go and do the lipid profile, these are the things they are checking. Want to check for the total cholesterol, want to know the triglycerides, the low density lipoprotein, and the high density lipoprotein. Are they within the normal range? So now let's type, what are the normal range of all these blood lipid profile? What is the normal range of total cholesterol? Please type. It's only some group of people that are responding. Type, what is the normal level of high density lipoprotein? I mean, total cholesterol, your triglycerides, your high density and low density. So let's start with total cholesterol. Total cholesterol should be what? 200. Just type 200. Should it be more than 200 or it should be lesser? Cholesterol 0.6. No. Total cholesterol should be less than 200. Should be lesser. Thank you. Should be lesser than 200. What about triglycerides? Okay, thank you. Less than 200. Triglycerides. Thank you. Less than 150. What about low density lipoprotein? Low density 100, less than 100. Less than 100. Thank you. Then high density lipoprotein should be what? High density lipoprotein. Above 600. I've never heard of that in my life. So I don't know where that person got that from. High density lipoprotein above 60. Okay. Some will say above 40, 40 to 60. Thank you very much for your responses. Thank you very much. So please, let's master it. Very, very important. Master it. Let it be at the back of your hand like it is, so that we not use it to eat. Okay. So which one is the good cholesterol in the body? Out of all these ones I've mentioned. When you are talking about good and bad cholesterol, which one is the good cholesterol? What do we call the good cholesterol? Good one. Thank you. High density, like low density is not low density. Low density is not a good cholesterol. That person is just imagining and just maybe you think because it is they say low density. So automatically you thought that is the correct answer. No, you are wrong. High density lipoprotein is the good cholesterol in the body. And it should be above 40 or 60. Some will say, we have different school of thoughts. So some will say 60. So when cholesterol, triglycerides, and low density lipoprotein level are elevated, the client is at risk of what? Coronary artery disease. That is the meaning. Immediately all these bad cholesterol, immediately all these total cholesterol, triglycerides, low density, immediately they go beyond their what? Beyond their normal range. That means the patient is at increased risk for coronary artery. So in many cases, diet alone will not lower blood lipid levels. Some people, and it's not about stature. Please let's take note. Someone can be fat and their lipid profile will be okay. So it is not by stature. And someone can be what? Can be thin, or how will I put it? Can be very slim. And their lipid profile will go out of this world. So it is not by stature. So diet alone will not lower blood lipid level. Therefore, antilipidemic medications have to be what? It has to be prescribed. It has to be what? Prescribed. So you can manage it with what? With medication and with nutrition too. So HMGA-CoA reductase inhibitors, that's the first thing we are talking about. It lower cholesterol level by inhibiting formation of this particular HMG-CoA is an enzyme. I've told you, I didn't remember the particular lecture. I told you that when you hear the word ASC, that means what? Enzyme. So it is an enzyme that is required for the liver to synthesize what? Cholesterol. So the liver cannot synthesize cholesterol in the absence of this particular enzyme. So that this particular HMG-CoA reductase inhibitors, it will now what? It will inhibit the formation of this what? Of this enzyme. It will inhibit it. So it is effective in decreasing what? Low density lipoprotein and then increasing high density lipoprotein. So what this medication will do is that it will decrease the what? The level of bad cholesterol in the body, and it will now increase what? The production of high density lipoprotein. It can also lower the triglycerides in some patients. And most of this medication ends in what? Statin. Now, please do not mix it up. Which other medication is ending in statin and it is not antilipidemic medication? Let's type. So that you not go and see any statin and say, oh, Mrs. Farino has told us that medication that ends in statin is an antilipidemic. I'm not the one that said that. Thank you, nystatin. Thank you. Nystatin is what? Antifungal. Thank you. So please don't mix it up. It's not a drug that ending. I'm just telling you for example that okay, most of the medications in the they are ending in what? In statin. Yes. So that will be easy for you to remember. Atorvastatin, simvastatin, my pharmacology is funny. Sometimes I don't what I do is I don't cram pharmacology. I don't cram medications in my head. Who cram we have millions of medications in this world. So how will I start cramming? But I make use of suffix. If I know that okay, this particular medication has a particular suffix or it has a prefix, I will just copy the prefix and put them in my head or the suffix. And if there are exemptions to them, I will also take note of the exemptions. Take for instance, now we have nystatin. I will never go and make the mistake and say nystatin is antilipidemic. So that is how I learn my own pharmacology. So I don't cram pharmacology in my head. I don't, because how many names do you want to cram? So that's what I'm trying to say. So I think that will actually help us when to know the name of drug in case you see it in exam, any kind of exam you are writing, and you see, you go be like, okay, since it is ending in statin, then and you can read the scenario surrounding the medication. If it's an antifungal now, they will not go and mention atorvastatin because it doesn't relate. Are you getting what I'm saying? So that's just a tip on how to master your pharmacology. So indication, you use it for hypercholesterolemia, primary and secondary prevention of cardiovascular events. Patient with type 2 diabetes and coronary diseases can use it. They are all, this medication can also affect the heart. Then headache is a side effect, rash, GI disturbances. Another one is myopathy, myositis, rhabdomyolysis. So now let's pause a bit and talk about this rhabdomyolysis. What do we mean by rhabdomyolysis? Because this is the most dangerous side effect of antilipidemic medications. The most dangerous side effects. So what do we mean by rhabdomyolysis? I don't know if my pronunciation is correct anyway. Or rhabdomyolysis, I don't know. What do you understand by rhabdomyolysis? Rhabdomyolysis. You have no idea. Okay. All right, too. Who have an idea of rhabdomyolysis? Then another thing that will help you, even if you have not heard about a word before, just break them down into syllables and think about it. These are English words that are just conjoined together just to confuse us. So you break them down. Rhabdo, myo, and lysis. Myo means muscles. Lysis means breaking down. Thank you. Destruction of muscles. So this particular rhabdomyolysis is the most dangerous side effect of antilipidemic medication. So the muscle fibers are being broken down. It will be broken down, it will begin to destroy it, and it breaks down into a particular damaging protein, a destructive protein. We call it myoglobin. So these myoglobin are released into the what? Into the bloodstream. And these myoglobin are they are very dangerous to the kidney. So patients will begin to what? This rhabdomyolysis, patients will start complaining of muscle pain, terrible muscle pain. So when your patient is on antilipidemic drug and the patient, after some days, the patient is telling you that, oh, my muscles are aching me, I'm having fatigue, my muscles are pain. The patient is complaining of muscle pain, fatigue. Then please start suspecting rhabdomyolysis. Start suspecting rhabdomyolysis. Patient will start complaining of muscle pain, muscle ache. And because of the terrible protein, this myoglobin that is released, the kidney can pack up before you know it. Because it is very dangerous to the kidney, the patient will start manifesting oliguria. There will be dark red urine. Patient will start, it's not like hematuria now. It's not like hematuria. These are the signs and symptoms that patients will display. And this medication is hepatotoxic. So please take note, that's another one. Another two major complications, side effects of antilipidemic, rhabdomyolysis, hepatotoxicity. So there's liver injury with increase in level of serum transaminase. So by the time you check the liver enzyme, it will go above the normal range. to go above the normal range. Then I forgot to tell you that this rhabdomyolysis, how can you treat it? You treat it with aggressive fluid replacement, aggressive fluid therapy. Aggressive fluid therapy. That's what you use. So you treat it with aggressive, you load your patient with IV fluid so as to flush out this terrible what? This protein from the body. You don't want the kidney to damage. I told you that if you are not careful before you know it, within a twinkle of an eye, that damaging protein to destroy the what? To destroy the kidney. So you don't joke with it. You manage it aggressively with IV fluid therapy. Then lovastatin is highly protein bound and should not be administered with anticoagulants. I don't know if I mentioned it when we were talking about anticoagulants. You don't administer lovastatin with anticoagulants. Lovastatin should not be administered with gemfibrozil. It shouldn't be administered. Gemfibrozil is also a type of antilipidemic. We'll still get them. Then you administer lovastatin with caution to client taking immunosuppressive medications. Then this medication is contraindicated in viral or alcoholic hepatitis. It's contraindicated in patients with pregnancy. Nursing responsibility. Instruct patient to report unexplained muscle pain or tenderness. I've spoken about it. You monitor the liver function. You monitor the kidney function too. Very, very important. Then inform women of childbearing age about the potential for fetal harm. Should they become pregnant? Administer medication in the evening without regard to meals. You don't want to administer it with meal, except for lovastatin, which is taken with evening meal. This is an extended release tablet taken at bedtime. Instruct patient about dietary changes to reduce weight and cholesterol. So when a patient is on antilipidemic, they wouldn't say, okay, because they're already taking medication and they'll start eating any kind of junks. Yeah, they have to be on dietary restriction too. Instruct the client to have an annual eye examination because the medication can cause cataract formation. If lovastatin is not effective in lowering the lipid level after 3 months, discontinue it. When a patient is on the medication, avoid grapefruits so as not to alter the absorption of the medication. Now, another one is bile sequestrants. Bile sequestrants. These bile sequestrants, they bind with bile acid in the small intestine, which prevents absorption of cholesterol. It prevents absorption of cholesterol. And it should not be used as the only therapy in clients with elevated triglycerides. So you can use this particular medication. Example is cholestyramine. So it should not be used as the only therapy in clients with elevated triglyceride levels because they may raise triglyceride levels, even though it's an antilipidemic medication. What are the side effects? Constipation, gastrointestinal disturbances like heartburn, nausea, belching, and bloating. Nursing responsibilities. Let me see if I've not been talking to myself. This cholestyramine, we have all used it before. Who has never seen cholestyramine before? Who has never seen it or used it? It's a very common medication. Cholestyramine. We use it a lot. Let's respond. Okay, someone say anti-itching. Okay. Yeah. Prevents itching. So in which condition do you use this cholestyramine apart from antilipidemic? So you use it for itching, yeah. Okay. So in which condition? The person that said for itching, which patient were you managing when you use this cholestyramine? What happened to the patient you used it for? High bilirubin in the body. Yeah, high bilirubin in the body. Yeah, which condition? There is a particular condition where we use this particular cholestyramine. So maybe we might not know that you are an antilipidemic. Nobody knows. Okay. Thank you. Liver disease. Thank you. Liver cirrhosis, hepatia, we use it. The patient with liver cirrhosis. When you were because somebody says type that use it for itching. And when the patient has liver cirrhosis, they come up with itching a lot. We are not going into liver cirrhosis now. So please let's move on. That's another entire topic on its own. So I just want you to mention, you can use this in a patient with liver problem, liver disease. So cholestyramine comes in a gritty powder that must be mixed thoroughly in the juice or water before administration. You know, it's a powder. You have to dilute it in water. You know the way it will foam. So monitor the client for early signs of peptic ulcer, such as nausea and abdominal discomfort, followed by abdominal pain and distension. Instruct the client that the medication must be taken with and followed by sufficient fluid. Then the last one, I think, for today is fibric acid derivatives, also known as fibrates. You can call them fibrates. They lower blood triglyceride level by increasing degradation and reducing the hepatic production of low density lipoprotein. You know, I told you that this low density lipoprotein is a bad cholesterol. So fibrates will lower the what? To reduce the hepatic production of this low density lipoprotein by the liver. Example is gemfibrozil, fenofibrate, clofibrin, and all these 5. So there's something common to this medication. There's the word 5 is there. 5, gemfibrozil, 5, fenofibrate, clofibrin. So it is very, very common to them. So gemfibrozil should not be taken with anticoagulants because they compete with protein sites. So if the client is taking an anticoagulant, the anticoagulant should be reduced during antilipidemic therapy, and IRM should be monitored closely. Do not administer gemfibrozil. You don't want to administer it with HMG-CoA reductase inhibitors because it increases the risk for myositis. We just finished talking about it, that they cause rhabdomyolysis. They monitor vital signs, monitor liver enzymes. They monitor serum cholesterol and triglycerides level. Instruct the client that it will take several weeks before the lipid level decline. So if your patient is on this medication, in fact, most antilipidemic drugs takes a long time before they start working. So if a patient approach you and say, nurse, I've been taking this medication for about 7 days now, and I'm not even seeing any improvement. It's not working. Please, I cannot stop using it. So you know what to tell your patients. You know what to tell your patient that, this medication takes several weeks before the lipid level declines. So the patient tell you that, they are just the medication is not working. My lipid profile is not doing this, it's not changing, it's not that. So you know what to tell your patient. Instruct the client to restrict intake of fat, cholesterol, carbohydrates, and alcohol. So when the patient is on this medication, they should restrict their intake of fat, cholesterol, carbohydrates, and alcohol. Instruct the client to follow an exercise program, very important, to shed weight or to reduce, to also burn all this excess cholesterol in the body. Instruct the client to have an annual eye examination and report changes in vision. Instruct the client with diabetes mellitus who is taking gemfibrozil to monitor their blood glucose level regularly because it can affect it. Then instruct the client to increase fluid intake. So we have come to the end of the lecture. Some people have even left the class. So let me stop recording.